After we have finished this, we want to start with the second part of the lens. And the second part of the lens is the main part, the main disease, the main pathology that we associate with lens, cataract. Okay, everybody? Start with cataract. Now, if I ask you the definition of cataract, or if I tell you the definition of cataract, I'll probably be making fun of you. Yes? Yes, probably easiest definition I will. Any opacity in lens. All of us know that. Lens is transparent, and if due to whatever reason, everybody, the lens becomes opaque, we give it one word, and that is cataract. So, any opacity in lens. As simple as that. Clear cut. Now, my question to you, everybody, if you think about it, let's say a person has cataract. What will be the symptom? What will be the common symptom of all patients of cataract? Lens was allowing the light to go inside and fall onto the retina. Now the light will be obstructed. So the patient will complain of visual loss. But as soon as you say loss of vision, I will ask you, what kind of loss of vision? Gradual or sudden? Painless or painful? Simple words. So what I am trying to ask you is, everybody, cataract causes which type of loss of vision? Gradual or sudden? Gradual or sudden? Will it occur once and that to a greater magnitude, or will it be slowly progressive? Yes, it will be slowly progressive. As the opacity increases, the loss of vision will increase. Will it be painless or painful, everybody? Painless or painful? Cataract, inflammatory, non-inflammatory? Yes, painless. So now if I ask you a question, what is the most common cause of gradual painless loss of vision? Out of all the pathologies, everybody, what is the most common cause of gradual painless loss of vision? What should be the answer? Obviously, the topic in discussion here, cataract. Okay? It causes gradual painless and it is the most common cause. Now, if I ask you a similar question, try to understand the difference. What is the most common cause of blindness? What is the most common cause of blindness? We are talking about India, obviously, guys. Most common cause of blindness in India. Anybody? Can you reflect on this? I know a PSM based question, guys, but ophthalmology related PSM based question. What is the most common cause? Are you saying trachoma? Are you saying refractive error? Are you saying any of that? All of those are wrong, everybody. The answer is again cataract. The answer is again cataract. Okay? No confusion? Now, everybody, blindness. Blindness, this is a word which is related to community ophthalmology. Here, we will need to know two things, everybody. Number one, name of the program. And number two, definition of blindness. Please remember that they were changed in the year 2017. Both the things, the name of the program as well as the definition of the blindness. Okay? So, I'll ask you here. You will see this topic getting repeated in community ophthalmology lecture also, guys. But I'm just clearing it here for you because this has been kind of a recent change. Program. What is the name of the program now in India, everybody? Program for blindness. The earlier name was NPCB. Now, two letters have been added, VI. NPCBVI. What is the full form, guys? National Program for Control of Blindness and Visual Impairment. So NPCBVI, that's the name now, guys. Okay, for blindness and visual impairment. Now, what about the definition? What is the definition, everybody? Definition of blindness according to NPCBVI. The definition is visual acuity or vision, basically, less than 3/60. Less than 3/60. Please remember, this is the change. Earlier the definition used to say less than 6/60. Less than 3/60 in the better eye with best possible correction. Visual acuity less than 3/60 in the better eye with best possible correction. Okay, that after all the treatment, surgery, blah blah blah, everything, then also the visual acuity is not improving to more than 3/60 in the better eye out of the two. Or visual field less than 10 degree. Visual field less than 10 degree. So that's the new definition, everybody. Please do remember it. There should be no confusion. These were changes done in April 2017. They will be asked. They will be asked and they will be asked. No two doubts about it. Okay, done? Now coming back to the topic cataract, everybody, this is just a little bit about the PSM part, everybody. Now, cataract, everybody, we know what is cataract, what will be the main symptom of the cataract. But what are the risk factors for cataract? There are various risk factors for cataract, everybody. So now, as you can see on the screen, depending on the risk factor, there is a different pathomechanism. So if we talk about age, why does cataract occur with age? This occurs due to oxidative damage. Okay, everybody. If we talk about sunlight, we say exposure to sunlight, ultraviolet A or B. This occurs due to hydration. Then it can also occur in diarrheal dehydration due to denaturation of proteins. Due to vitamin A, C, E deficiency. A, C, E are antioxidants. So you understand yourself that there will be opacification of lens fibers with fibrous metaplasia in vitamin A, C, E deficiency. Similarly, you can say in smoking, there will be accumulation of pigmented molecules. The name of the pigmented molecules are given. Due to steroids, there is disturbance in osmotic balance. And genetically, there can be lots of causes. One of those is mentioned here. Okay. These can be asked, everybody. Just try to remember some of the important points, just like with age, like with smoking, like with vitamin A, C, E deficiency, and with sunlight. These are the main things that I want you to remember, guys. Risk factors for cataract and their pathomechanisms. Done? Just a rectification topic. Just learn them, guys.
So now let's start with the classification of the cataract, guys, or the types of cataract. So as we can see on the screen, the types of cataract can be broadly divided into two groups. The first is acquired and the second is congenital. I think two basic words, the names all of us know. Acquired means due to some other cause cataract has occurred after birth, and congenital means present since birth. So the acquired group of cataract can be due to some metabolic disorders. It can be due to trauma. There are various types of trauma as we will study. It can be a complicated cataract. As we will study, it is clear from the name, it is a complication of some other disease, so some other cause, acquired cause. Or it can be senile or age related, the most common group per se, right? Congenital is divided into two groups, infantile and developmental. What are the differences? We will see as we move on. So these are the basic 6 groups of cataracts that we are going to study. We start first of all with metabolic cataract. Metabolic cataract, guys, as the name itself tells, we are talking about cataract due to some metabolic disease. So what is the main metabolic disease that we are talking about here, everybody? First, we talk about diabetes mellitus. Now, I hope all of us know that what is the name of the famous name, I can say, of the cataract caused by diabetes mellitus. We have all come across, read it somewhere, I hope. Yes? Yes, guys. A lot of you, I know, are answering the correct answer here. Snowflake cataract. Okay. Now, apart from the name, the examiners ask you what is the site of the cataract. Site of the cataract means they're asking the position in the lens. As we have read in the anatomy, there is a nucleus, there is a cortex, there is a capsule, anterior, posterior. So what is the site of the lens? Snowflake cataract affects the cortex. So we can say it is a cortical cataract. Apart from these two simple questions, guys, please remember that snowflake cataract is more common in type 1 diabetes mellitus, or I can say in the young patients. Okay? Whereas diabetes mellitus also causes something known as presenile cataract. This is more commonly seen in type 2 diabetes mellitus. So we can basically say that diabetes is causing two cataracts. One is the famous name snowflake cataract and the other is presenile cataract. So what do we understand by the name presenile, guys? So senility means with old age. So presenile means a cataract which should actually have occurred in old age but is occurring before that old age. Okay. So how do we define presenile cataract? We can say senile cataract before 50 years. So the same cataract that we should have seen normally after 50 years of age, in diabetes, it is seen in slightly younger population. Usually we encounter patients around 40 to 45 years of age showing the same changes, and on history they have a long history maybe or a short history of diabetes mellitus somewhere. Okay, I hope we are clear. This pre-senile cataract, everybody, occurs due to, this has been a question which has been asked previously, everybody, occurs due to increased carbamylation of crystallins. Crystallins, the proteins, guys. Again, we have read it in the anatomy part, right? So increased carbamylation of crystallins, this is what leads to pre-senile cataract in diabetes mellitus. I hope we are absolutely clear about this. Also remember, everybody, diabetes mellitus also causes, if we are talking about the ocular manifestations here, I can say it also causes diabetic retinopathy, which has been discussed in detail in the retina chapter, guys, and it causes fluctuation of refractory errors. The second part, everybody, the fluctuation in refractory errors, it is usually common in patients who do not have a stable blood glucose, plasma glucose, right? So their sugar keeps on fluctuating. Someday they will report that our sugar goes up to 300, someday it comes back to 110. So they are saying that we do not have a stable glucose, plasma glucose level. Along with the fluctuation of the glucose levels, the patients keep on repeating fluctuation of refractory error or the power of their refractory error. So it is very common that we encounter such patients who come on one visit in 1 month, they have an absolutely different refractory error power, let's say -1, and on the second visit after 1 month they will have -3, but then again in the third month they will come back to -1. So you can never satisfy these patients with a spectacle because their glucose is leading to fluctuation of refractory errors. You have to point this out to a patient. A very good part of being a clinician is to be able to inform the patient that you are having such a problem and you will continue to have such a problem if you have an unstable diabetes mellitus. I hope we are clear about the diabetes mellitus and its manifestations, everybody. Now, what we should further know is how does a snowflake cataract look like. So let's see this image, everybody. I hope first of all we know how to recognize what we are looking at. The white part is the sclera, everybody. The central whole part is the cornea, if we are talking about the outermost layer. And now in the cornea we can see the iris behind the cornea. In the center we can see the pupillary area. So through the pupillary area we are able to see the lens. Again, anatomy, I hope we know. Now on the lens all of us can see a snowflake or a snowstorm kind of appearance, as if it had just snowed down on the lens, everybody. Yes, so very easy to diagnose by the look, everybody. Snowflake cataract. I hope all of us are clear about this. Yes. Now moving on, everybody, let's move on to the second cause of a metabolic cataract. The second cause, I can say, is another important disease, galactosemia. A disease which primarily affects the infants. Yes. Now, what is the famous name of the cataract caused by galactosemia? So, galactosemia causes oil droplet cataract. Oil droplet cataract. What is the site of the oil droplet cataract, everybody? Posterior subcapsular. Posterior subcapsular. Now, what do we mean by posterior subcapsular? I hope you remember the structure, the anterior surface and the posterior surface. So this is my anterior surface, this is my posterior surface. So this is my posterior capsule. So just below the posterior capsule. Okay, everybody. So this will be posterior subcapsular cataract. Please remember about galactosemia. Very, very, very important point, guys. This is the only reversible cataract. When I say only reversible cataract, I mean to say that as galactosemia is resolved, the cataractus changes or the opacity in the lens also gets resolved. There is no other cataract about which we can say the same thing, that if you put this medication or if you, treat the cause, the cataract will go away. No. If cataract has occurred, the only treatment will be surgical, except the only exception is galactosemia, right? Now, let's see the photograph of an oil droplet, everybody. Now, I hope again you can see that in the lens in the center, everybody, against the fundal red reflex in the center, if I mark it, everybody, you are able to see a faint oil droplet, everybody. Yes, so this is the kind of appearance that you get, oil droplet cataract. Now that we know about the ocular manifestation of galactosemia, let us discuss galactosemia a little bit, everybody. What happens in galactosemia? Galactose is not able to convert into glucose. Now, due to that, galactose and its metabolite. What is the name of the metabolite, guys? Galactitol, which is also known as dulcitol. They will accumulate in lens. Okay. And when they accumulate in lens, they lead to what we have discussed, oil droplet cataract. Now, if we talk about a little bit of the pediatric part or the medicine part of galactosemia, what is the enzyme which converts galactose into glucose? So there can be three enzymes, everybody. The first enzyme is galactose 1 phosphate uridyl transferase. The second is UDP galactose 4 epimerase, and the third is galactokinase. Okay, so if there is deficiency of galactokinase, it presents with only cataract. But if there is deficiency of the first two enzyme, the galactose 1 phosphatidyl transferase or the epimerase enzyme, it leads to, everybody, mental retardation, failure to thrive, hepatosplenomegaly, and all the other manifestations, everybody. Okay, so we need to remember this, that what we are talking about in terms of causing cataract occurs due to the deficiency specifically of the galactokinase, everybody, right? Now, that's a little bit about galactosemia for all of us, everybody. Moving on to the third metabolic disease. The third metabolic disease is myotonic dystrophy, the third cause of metabolic cataract. Again, what is the famous name of the cataract, everybody? This everybody, all, I think, remembers. Yes, the name is Christmas tree cataract. What is the position of Christmas tree cataract? Again, posterior subcapsular. So, just like galactosemia, everybody, galactosemia was also causing a posterior subcapsular cataract, and myotonic dystrophy is also causing a posterior subcapsular cataract. Let us see the image of what a Christmas tree cataract looks like and why is it named a Christmas tree, everybody. So this is the image of a Christmas tree cataract. I know you are saying, sir, this does not look like a Christmas tree at all. This is how we are used to drawing a Christmas tree now since our childhood, green colored. Yes, but this does not look like this. Yes, I know it doesn't look like this. But if we see, we can say it is an irregularly shaped, yes, or we can say some scattered opacities are there and which have some iridescent sheen to it or some shining to it, different colors. So what do you do on a Christmas day? Yes, we have seen a lot of cartoons that we decorate, everybody, Christmas tree with different colors, hangings, everybody. Yes, some green, blue lights and everything. So this is what it is looking like, an irregularly shaped tree which has been decorated, everybody, and that is why it has been likened to a Christmas tree and we start calling it a Christmas tree cataract. I hope there is no confusion in this. Right, guys? Done. Now, let's move on to the next cause, everybody. The next cause is a disease which I hope all of us have heard of and read of also. Yes, Wilson's disease. So what is the famous name of the cataract that is caused by Wilson's disease? Sunflower cataract. Now, the sunflower cataract does not have a particular position. It affects a lot of areas of the lens. It can affect the nucleus as well as the cortex as well as the anterior capsule or anterior subcapsule. So nobody will ask you that. But what we should know in sunflower cataract, why is the cataract occurring? It is occurring due to deposition of cuprous oxide. It is occurring due to deposition of cuprous oxide. Let's have a look of what a Wilson's disease sunflower cataract looks like. Everybody, you can see the photograph of sunflower on the right side. Now compare this to the photograph of the cataract which is seen. I hope more or less you find it similar, everybody. Yes. So it is forming a stellate pattern in the periphery where the flower petals will arrive from, and in the center you can see a nice bud with all that dotted appearance, everybody. Yes. So that is why it has been likened to a sunflower cataract. I hope we are absolutely clear about this. Now, if we remember, everybody, Wilson's disease also causes another manifestation which is known as, yes, I know all of you know that, KF. What is the full form of KF? KF ring is Kayser-Fleischer ring. Kayser-Fleischer's ring. Yes, everybody. What is Kayser-Fleischer's ring? Kayser-Fleischer's ring is deposition of copper. Yes, Wilson's disease is a problem of copper metabolism. So everywhere copper is getting deposited. Yes, deposition of copper in the periphery of cornea. First of all, we should know where is it deposited, in the center of the cornea or the periphery of the cornea. It is deposited in the periphery of the cornea. It is important. You will understand why. In which layer? In which layer of the cornea? We remember there are 6 layers of the cornea, I hope. Yes. So which layer of the cornea, everybody? Yes. Answer is Descemet's membrane. So it mainly is getting deposited in the cornea. Deposition of copper in the periphery of the cornea and Descemet's membrane. But it also extends into the angle of anterior chamber. When I say angle of anterior chamber, I hope you realize basically I'm talking about the trabecular meshwork, glaucoma chapter, everybody. Yes. So it also extends from the cornea in the periphery, it extends into the angle of anterior chamber up to the trabecular meshwork. So that is what a Kayser-Fleischer ring is. Now my question to all of you, if it is deposition in the periphery, that is what is important. Will it lead to any loss of vision? See, the light is primarily going through the center of the cornea, through the pupil onto the retina. Yes, and that is how image is getting formed. So if something is getting deposited in the periphery of the cornea, it is not going to cause any visual loss. So please remember, there is no visual loss due to Kayser-Fleischer ring. Okay. Now, let's see the photograph of a Kayser-Fleischer ring, everybody, if you are interested. Yes. So what do you see, everybody? It is copper. So what kind of color is copper, everybody? If I mark between my arrows, everybody, you will be able to see that we have in the periphery a golden brown ring. So can I say it's a golden brown ring, everybody? Am I clear to everybody? In the periphery of the cornea. But it is getting easily seen in this patient. Why? Because as you see, the iris is light colored, light gray or blue color. Yes. So on a light gray or blue background, you are able to see a golden brown color. But in Asians, everybody, like us, everybody, we have a dark brown iris. Over a dark brown iris, it is very difficult to be able to see a golden brown deposit, everybody. So in Europeans and in Americans, we can say, in Westerners, even with a torchlight, with a naked eye, it is possible to see a Kayser-Fleischer ring. But in Indians or in the Asians, again, I am saying it becomes slightly difficult. Okay. Now, let's discuss some more about the Kayser-Fleischer ring, everybody. Kayser-Fleischer ring is seen in all patients with neurological manifestations. But it is seen in around 50% of patients with hepatic manifestations. Okay. So that is the first, hepatolenticular degeneration. Yes, we know Wilson's disease. So if it is only hepatic manifestations, the chances are only in 50%. But if there are neurological manifestations occur due to deposition of copper in medicine, biochemistry, guys. Yes, basal ganglia. So if copper has been deposited in the basal ganglia and you are presenting with the neurological manifestations, then it is almost always sure that the patient also has what, everybody? The ocular manifestation, Kayser-Fleischer ring, everybody. Also remember that KF ring starts superiorly, then inferiorly, and then laterally. So it is not going to affect the whole circumference at a point. So at the earliest beginning, you will be able to see in the superior periphery, then the inferior periphery, and then 360 degree, everybody. Okay. Now, Kayser-Fleischer ring, how do you treat it? Number one, we can use chelating agents. Chelating agents like penicillamine and trientine. Okay. The KF ring usually will disappear after 3 to 5 years, but the therapy is lifelong. Otherwise, we see it reappears. Okay. So chelation therapy is usually given lifelong in these cases. The second treatment can be, we can say, maintenance therapy. Maintenance therapy is by using zinc acetate. What does zinc acetate do, everybody? Zinc acetate stops the absorption of copper. Okay. So these are the two treatment options available to us. I hope we are clear about Kayser-Fleischer ring. Questions do get asked about Kayser-Fleischer ring. We have heard the name so commonly, everybody, since first year, since biochemistry, we start hearing it, everybody. So that is why it becomes important to be able to remember what a Kayser-Fleischer ring is, the image and all the points that I have explained to you. Also remember about KF ring, that KF ring is not pathognomic of Wilson's disease. KF ring can also be seen in other disorders like primary biliary cholangitis or neonatal hepatitis. Okay. That's all about KF ring. That's all about Wilson's disease. I hope you have been able to learn. KF ring is a often asked question, everybody, because Kayser-Fleischer ring we have heard a lot, everybody, since our beginning, since our first years we have been reading this in biochemistry and now also in ophthalmology. Right, guys? Now, moving on to the last cause of metabolic cataract, everybody, parathyroid tetany. Now the question comes, why does parathyroid tetany cause cataract? So the answer is parathyroid tetany causes cataract due to hypocalcemia. Now this hypocalcemia can lead to cataract in children as well as in adults. So I can say in adults or I can say in children, that means it can also cause congenital cataract. Okay. So this is a cause of both the groups, acquired as well as congenital. If it is causing cataract in adults, it causes anterior or posterior subcapsular. Just like we had discussed posterior subcapsular in galactosemia and in myotonic dystrophy, everybody, it can be posterior or anterior subcapsular. Whereas if it is causing congenital cataract, it leads to lamellar cataract. This name we will discuss a little later on when we start our second group of cataracts, that will be congenital. Alright, guys. So these are the 5 important causes along with the images that I have shown you. I hope you will be able to remember. Diabetes mellitus causes snowflake cataract, galactosemia causes oil droplet, everybody, myotonic causes Christmas tree, and lastly Wilson's disease importantly causes sunflower cataract. So with this, we are done with our first group of cataract, that was metabolic acquired cataract. Now we move on to our second group, that is traumatic, and then the third group, that is complicated. Okay, so let's start with traumatic cataract. Now, traumatic cataract, I think by the name itself, it is very clear we are talking about trauma here, everybody. Traumatic cataract, yes, but there can be various types of trauma. So the first type of traumatic cataract occurs due to blunt trauma, blunt ocular trauma. What is blunt ocular trauma? Basically a fist, yes, a fist injury, or let's say a tennis ball hitting your eye, yes. So any blunt, no sharp object, everybody, blunt injury to the eye, blunt trauma. What is the name of the cataract? Again, it is a very famous name. You may have come across it, guys. Yes, it is known as a rosette shaped cataract or a rosette cataract. Now, rosette shaped cataract is basically the name which is being given to a stellate pattern or a multiple edge star pattern. Something which is looking like a rose, everybody, a flower, a bunch of rose, everybody. Yes, that is why the name. What is the position, everybody? The position is, again, what we are reading again and again, posterior subcapsular. Okay, so now let's see the image, everybody, how easy it is to be able to visualize and then recognize and answer if it is asked in our MCQs, everybody, a rosette shaped cataract. I hope as soon as you see this photograph, there is no doubt that it is a rosette shaped cataract, everybody. Beautifully formed rose shape or rosette shape cataract. Okay, everybody, stellate pattern. As I said, stellate pattern, everybody. This is the kind of pattern we are getting. I hope there is no confusion in this image. Moving on, everybody. The second type of trauma that can cause cataract, I will say radiation trauma due to infrared rays. Okay, this causes a cataract which got famous by the name of the profession where it was occurring, everybody, glass blowers cataract. So during glass blowing, when the temperatures are upwards of 1000 degrees Celsius, everybody, when they're trying to mold the glass into various different shapes, a lot of infrared heat is, or infrared radiation is emitted. So if the professionals are not using the protective equipment, everybody, they are prone to get the cataract. So it is an occupational hazard, and based on that occupation only the name has been given. But if we talk about the pathology of this cataract, everybody, the pathology of this cataract is basically exfoliation, true exfoliation of anterior capsule. So the site per se is the anterior capsule, and it is calling exfoliation of the anterior capsule, leading to the cataract famous by the name glass blowers. Now, lastly, everybody, the last type of trauma which can cause cataract is electrical trauma, I can say. So if you are unfortunate enough to get struck by lightning, you have gone out to enjoy the first monsoon rains, everybody, but there is a lightning strike and you brrr. Or if you have lived your 5 years in a government medical college hostel, everybody, so you must have been prone to electric shocks, everybody. Yes. So in any case, basically what we are trying to say is current flowing through the body. We get anterior capsular opacities. There is no fancy name for it. We are just saying that opacities are occurring on the anterior capsule of lens. And that's all about the small topic, traumatic cataract. The second group of acquired cataract done. Now we move on to the third group of acquired cataract, that is complicated cataract. Now I hope it is very clear from the name itself that it is a cataract and it is a complication of some other disease. Complicated cataract. Yes. So the first question that I ask myself is, what are the causes of this complicated cataract? What are the diseases which are leading to this cataract? So number one, I say the most common cause is uveitis. Uveitis is inflammation of the uvea. Yes. The second important cause is the refractory error myopia. Yes, if you have pathological myopia or if you have degenerative myopia, there are greater chances of getting cataract. Number three, everybody, angle closure glaucoma. And last important cause is a disease of the retina, retinitis pigmentosa. Okay. I have written 4 important causes for you on screen. The mnemonic becomes very easy to remember. If you see U for uveitis, M for myopia, A for angle closure glaucoma, and R for retinitis pigmentosa. So I remember it by a name called Umar, or I can flip it and I can remember it by the name Ramu. Both ways, guys, Umar or Ramu. Yes, both ways you can remember this. I prefer Umar because you remember U for uveitis, most common cause first. So even though I have just written 4 causes, everybody, this does not mean that there are only 4 causes. That is the point I am trying to explain to you. If you see the whole list, everybody, there can be 22 to 25 causes in toto, everybody. But these are the 4 more important causes. These are the 4 more common causes that we want to remember. We can't, or I don't expect you to remember 20 to 25. Nobody does. Yes. But I at least expect you to remember these 4 causes, everybody. Now, what is the appearance of this cataract? Appearance. So the appearance of complicated cataract has been called as breadcrumb appearance. As soon as I write breadcrumb, I hope you have been able to understand. Small opacity scattered all around. Assume that you have breadcrumb and you are throwing it to the birds to eat. So it will get scattered all around. Yes or no? So we have thrown breadcrumbs and it is scattered around small opacities. Breadcrumb appearance with polychromatic luster. Again, English, guys. Poly means multiple, chromatic means color, luster means shine. So all these breadcrumbs, when you throw light on them, they shine with multiple colors. Polychromatic luster, and that's the appearance, everybody. Okay. So just like all the other cataracts, after the appearance, what is the sight? If somebody asks you, the answer again is, I know we have said it a lot of times now, posterior subcapsular cataract. Right, guys? And that's all about our complicated cataract, the third group of acquired cataract. Now we move on to the so-called main group of cataract, senile cataract or age-related, everybody. The last group in acquired cataract that we are reading. Why am I calling it the main? Main because we know, we have heard that our parents, our grandparents all have got at some point of time a cataract surgery done. Why have we heard that? Why is it almost universal to hear this? Because it is an age-related change. In everybody, if we are of a certain age, an old age, senile everybody, we are going to get cataract. Now the question is, what is the age? So I ask you, what is the meaning of the word senile? Senile, senility. Do you know? You are saying old age. No, old age is not the meaning. The meaning is senility. If I say it in Hindi, people who know Hindi, senile basically means satya jana. So we use satya jana in a very, bad way or vulgar way. But basically the word senile is trying to tell you 60 years of age. Senility, 60 years of age. So we are saying an age-rated cataract is somewhere near that age. So the age is usually between 50 to 70 years. I am using the word usually so that you don't say that if cataract occurs in a 75-year-old, does that mean it is not 75, right? We are usually writing it occurs or presents between 50 to 70 years of age. I hope we are absolutely clear about this. Okay. Now, when we want to study senile cataract or age-related cataract, we say that we can divide it into 4 types based on the location of occurrence. How? Let's see. The first type of senile cataract I name nuclear cataract. As soon as I say nuclear cataract, what comes into your mind? What am I talking about? Nuclear. I am talking about, yes, I am talking about the nucleus of the lens. That means I am talking about which part of the lens, the center part of the lens or the peripheral part of the lens. So can I say, everybody, nuclear cataract is also central cataract? Because it is occurring in the nucleus or the center of the lens. Now, if it is a central cataract, everybody, let me ask you, what will the patient complain of? Patient complains of, I'll give you 2 options. Will the patient complain of more loss of vision in daytime, or will the patient complain of more loss of vision in nighttime? Daytime, nighttime, daytime, nighttime. Daytime? Why? Why? Because cones are situated at the macula, macula is central. Are you saying that? If you are saying that, you are wrong. It is way simpler than that. Everybody, in daylight, in sunlight, if I draw cross section, this is my lens. In front of the lens will be my pupil. Yes. At night, my pupil is dilated. But if I say in daytime, due to the sunlight, my pupil becomes constricted to control the amount of light that goes in. That means in daytime, the light which is actually going in is only going through the center of the lens. And what is there in the center of the lens, everybody? We have just now said cataract. So in daytime, will light be able to go inside? No. But in night time, everybody, the pupil will dilate. So in night time, when my pupil has dilated, now can the light go inside? Yes, it can go inside from the periphery. So the patient will say, I have difficulty seeing in daytime, but at night time my vision improves. So sir, I have become like an owl. मैं उल्लू बन गया हूँ sir. रात को ज़्यादा दिखता है. I see more in the night. I hope we are clear with this. Yes. So the patient complains of more loss of vision in daytime, or I can say improvement of vision in dim light. I hope you understand that both these lines mean the same thing, everybody. Yes, examiners usually use the second line in their questions. The question usually comes like, a patient comes to you complaining of improvement of vision in dim light or in night. What is the most probable diagnosis? So I hope you understand the answer here. Now, once we know this, everybody, let me ask you the next point. What is the pathologic change, everybody, which leads to nuclear cataract? So the answer is one word, and that one word is sclerosis. Nuclear cataract is occurring due to sclerotic changes in the nucleus of the lens. Sclerosis means something which is becoming more dense. Yes. So if I talk about the morphology of this cataract, everybody, will it become, the nucleus will become denser? That means will it become harder or softer, everybody? Yes, it will become harder. So we say it is a hard cataract. So morphologically, you will see that there is some cataract which is called as soft cataract, but nuclear cataract is called as a hard cataract. Now, what occurs due to sclerosis? Sclerosis leads to increase in density. Again, hear me. So it leads to increased refractive index of lens. Yes. Now, when the refractive index of the lens will increase, that will lead to increased power of lens. Do you understand optics? Yes, you have passed 11th and 12th, but do you remember that? If not, let us see, everybody, why refractive index increase leads to power increase. Everybody, let's say this is my lens and this is my air. Okay. Air's refractive index is 1. And if you're talking about the nucleus, as we've already read, the nucleus is somewhere 1.40. Just taking out the average. Yes. Now, the light rays which come, everybody, parallel, why do they converge? They converge in our eye. Our lens has a power. Why does lens have a power? Because of differing refractive index. So we know when light travels from a rarer medium to a denser medium, it converges. So let's say it is converging and this is my retina. Okay. So it is forming an image on the retina. Now the refractive index has increased to 1.50. So what is going to occur? The light rays that are going to come, they are going to have a higher difference of refractive index. That means they are going to converge faster. That means my lens will have more power. Do you understand what I'm trying to say here, everybody? Yes. So where will the image be formed in such a case? In front of the retina. And when the image is formed in front of the retina, we call it myopia. So we say sclerosis caused increased refractive index, which caused increased power, which led to index myopia. Am I absolutely clear about this, everybody? Yes. So just by one word, sclerosis, if our optics is good, we can understand how myopia is caused. Now, if we know our refractory errors, let me further ask you, what is myopia? So yes, I hope a lot of you have read. If you haven't, then please remember, myopia is loss of far vision, or it is also known as near sightedness. Again, basics, guys. Every basic piece of information can be used to make an MCQ. It can teach you another concept. So that is why I'm referring to this basic, because you will be able to understand the next point with it now. So now we know index myopia has occurred. Now due to index myopia, we say it leads to another phenomena. It leads to something known as second sight phenomena. Second sight phenomenon. Now, what is second sight phenomena? Everybody, let's try to understand. Second sight phenomena is improvement of near vision in a patient previously having presbyopia / hypermetropia. If you have read optics, or if you have read presbyopia in the first anatomy part of the video lecture series, everybody, you have already understood it. If not, let's understand, everybody. What is hypermetropia? Hypermetropia is the opposite of myopia, loss of near vision. So if a patient was already hypermetropic, he had loss of near vision. Yes, he was wearing a spectacle for that. But now he has developed nuclear cataract. Due to nuclear cataract, he has developed myopia. In myopia, he has lost far vision. And instead he has developed nearsightedness. That means he has lost his vision for far, but his near vision has actually improved. So the patient will say that before today I needed to wear a spectacle for near vision, but now I can see at a near object without the spectacle. Yes. So my near vision has come back. Second sight, it has come back again, everybody. The same with presbyopia, everybody. After 40 years of age, everybody has presbyopia. Yes, loss of accommodation leading to loss of near vision. So basically we are saying that nuclear cataract occurs after 50 years of age. By that time, everybody is presbyopic, everybody has lost their near vision. Yes, so think about your mothers and fathers, everybody. All of them would be saying that we have a spectacle which we use only for near work. Now, one day your mother went to some Neem Hakim, okay, somebody, yes. The next day she came and said, I can see near vision very clearly now. You will say, why? Your mother will say, because I went to that Baba, that Neem, that Hakim, whosoever, everybody quack in my language, and he did something, and that is why my near vision has come back. You will take your mother to an ophthalmologist. The ophthalmologist will say, no ma'am, you have nuclear cataract. That is why you have developed second sight. But your mother will say, no, it is magic. Earlier I needed spectacles for near vision, now I don't. So please understand that the patient, it becomes very hard for the patient to understand this, but you do. So I hope you educate them if you come across such a patient. Right, guys? So this is all about second sight phenomena. Now, if we see the way of teaching that I am doing here, I am writing in flowchart. Does not mean that they are only going to ask you a question straight out of the last point, second sight phenomena. See, they can ask you all the questions. They can ask you this, or this also. I'm writing them in connected form so that it becomes easier to remember by comprehension, right? One point leads to the other and you are able to remember a lot of information together. Yes? Now, moving on, everybody. The next question I would like to ask you is, what is the color of nuclear cataract? Now, this I expect even my third first students to tell. Third first students who are watching this video, interns definitely. I know I'm saying definitely, but you are wondering why. See, because in our postings in third first, which alas we have not done, a lot of us, we are taught to take a torch and see the cataract at least. At least that much I think we are taught. So have we seen a cataract? What is the color of the cataract? If you are going on to the theoretical knowledge, I am not bothered. If you are saying chalky white, pearly white, no. I am asking, have you seen a cataract? If you have, guys, then the answer would have been, it is yellowish in color. Okay. Now, this yellowish basically is denoting that there will be shades of yellow. So in grade 1, we say it is yellowish. In grade 2, it turns to amber orangish sunset color. Then as it progresses, it becomes brown in color. And finally, we say it has become black in color. So this is how basically we grade our nuclear cataract based on the color that we are seeing. Grade 3 brown cataract gets a name on itself. It is called as, yes, you've heard the name, cataracta brunescens. Whereas grade 4 black cataract is called as cataracta nigra or nigra. Yes. Okay, everybody. I hope we are clear about the names. Now the question, why is the color yellowish? Why is the color yellowish? So the answer is due to deposition of a pigment which is known as urochrome. Urochrome, I hope you are understanding urine color. Yes, urine color is also yellowish orangish. Yes, so the same pigment which is present in your urine is the pigment which is getting deposited on the lens here, everybody. Yes. Now, what will the patient complain of? If you have a yellow colored lens, will you have any specific complaint? You are saying, sir, it is cataract, so the patient will complain of loss of vision. Yes, I know. But any other specific complaint due to the yellowish color? See, understand, it is like wearing a yellow colored sunglass. If you wear a yellow colored sunglass, everything around you becomes slightly yellowish. Yes. Now this patient is wearing a sunglass inside the eye. You can say the lens itself is yellowish in color. So the patient says, everywhere I see something yellow. Yes. So the patient complains of yellow colored vision, which is known as xanthopsia. Xanthopsia word is derived from the xanthophyll pigment which is present in plants. If you remember, chlorophyll was green in color, xanthophyll was yellow in color. So xantho denotes yellow here, xanthopsia. So that is the name which the examiners may use in the MCQs, everybody. Okay. So what is the color? Yellowish, everybody. Why is the color yellowish? Due to deposition of urochrome, and it leads to xanthopsia. That's all about my nuclear cataract, everybody, starting from the basic fact that it is central, ending with the fact that it is going to cause yellow colored vision. Okay. So guys, now let us understand on how to identify a nuclear cataract on an image. Let's see the first image. What is this first image showing us? This is a slit lamp image showing a view of oblique illumination. What do we mean by that? So this is basically essentially what an ophthalmologist is looking at the eye when he is looking through the slit lamp. So a thin beam of light is thrown through an angle. So let's assume this is the patient. This is where my slit lamp is, and we are throwing an oblique light on this. Okay, a thin beam of light. So what are we seeing, everybody? First of all, the light will fall onto the outermost structure. So what is this outermost structure that you see, everybody? This slit. This is showing you the cornea. I hope you are understanding. Yes, we are slitting. We are taking the light in like this. So let's say I am the patient. So the light comes like this, falls onto my cornea first, then goes inside and illuminates all the structures inside, everybody. Okay. So first of all, the cornea gets illuminated. Then you see a black space. What is this black space, everybody? Anterior chamber. And then what you see here, everybody, going from anterior to posterior, this is your lens. Yes, I hope we are pretty clear about this, that this lens that we see, this is showing us all the parts, starting from the anterior capsule, then this nucleus you can see, everybody, then the posterior capsule you can see. Okay, everybody. Now, if you understand this image, let us see the second image of a nuclear cataract. Again, everybody, a slit lamp, oblique illumination. Again, light is coming from this direction, shining on the first part. This again becomes my, everybody, cornea. This whole black space becomes my anterior chamber. Now this you see the line shining here, this becomes my anterior capsule. And as we move in, we can see a dark yellow or an amber color in the nucleus, everybody. Yes. So this must be somewhere my grade 2 to grade 3 nuclear cataract. The examiners are not going to ask you the grade of the cataract. They're just going to identify. They're just going to ask to identify the cataract at most, everybody. I hope you understand the oblique illumination and the structure seen. We will be using such oblique illumination images in other chapters as well, everybody. In other topics like glaucoma, you will see such images being used again, right? I hope we are clear about the first senile cataract, that is the nuclear cataract. Moving on to the second type, everybody. The second type of senile cataract, I am calling it cortical cataract. Now again I ask you, nuclear cataract was central because nucleus was in the central. So cortical cataract, by virtue of its position, the cortex, everybody, will be what, everybody? Yes, peripheral cataract. So if my cortical cataract is a peripheral cataract, what will the patient complain of? Again the same fundamental. Yes, will the patient complain of more loss of vision in dim light or in daylight, everybody? Now it is in the periphery, so in dim light, when the pupil will dilate, actually the extra amount of light will not be able to go. So we say the patient complains of more loss of vision in dim light, or I can say night time. Yes. So loss of vision in night time. Loss of vision in night time is known as, yes, everybody, physiology, we have heard this word, I know, or at least in ophthalmology, to 100% we have heard this word, nyctalopia. Yes, loss of vision in night time, or I am saying dim light. Yes. Moving on, everybody. What is the pathology? What are the pathologic changes? So, cortical cataract occurs due to one word again, but that one word is not sclerosis. The answer here is hydration. The fluid is coming inside the lens, everybody, and that is why opacity is occurring. So again, if I ask you morphologically, nuclear cataract was hard cataract, cortical cataract will be due to fluid, everybody, it will be soft cataract. Yes. Now, due to hydration, what occurs, everybody? So a theoretical question has been asked previously, I think twice. What is the earliest pathologic change seen in a case of cortical cataract? So the answer is, due to hydration, there is formation of water clefts and vacuoles. Formation of water clefts and vacuoles. Or if we understand it, basically pockets of fluid are forming within the cortex of the lens. Okay. Now, as the hydration keeps on occurring, these pockets keep on enlarging. So let's say there are two pockets which enlarge and they coalesce with each other. Coalesce means they become one. So they are basically forming a layer of water. Yes. What is there in cortex, everybody? If you remember the anatomy, lens fibers. So this is a lens fiber. This is a lens fiber. Now, due to the coalescence of the vacuoles, everybody, what has formed between two layers of lens fibers, a layer of fluid has formed. So this is the kind of morphology that is present, everybody. A layer of fibers, a layer of fluid. Fiber, fluid, fiber, fluid. So sheets or layers can be called as lamella. So we say due to continued hydration, what occurs is lamellar separation. Okay. The sheets of fibers in the lens, everybody, cortex of the lens, they get separated by sheets of fluid or layers of fluid. After this, till lamellar separation, we have not been able to see any opacity. I hope you understand. These are just subclinical morphologic changes that are taking place. The first time we see an opacity is after lamellar separation. Wedge-shaped opacities are formed. When wedge-shaped opacities are formed, we start calling this cataract as cuneiform cataract. Okay? Wedge-shaped cuneiform cataract. Now, how will the opacities look like? Let's say if this is my pupillary view of the lens, everybody, in the center. Wedge shape basically means a pizza slice or the potato wedges that you eat, yes? So you will see in the periphery, see the important word is in the periphery because it is a cortical cataract. You will see wedge-shaped opacities like the diagram that I am drawing here, everybody. Yes, wedge-shaped opacities in the periphery, I hope you can see. These opacities are most commonly seen in the inferonasal quadrant. Inferonasal quadrant. Done? Now, after cuneiform cataract, we say immature cortical cataract is seen. Immature cataract. Okay, you have come across this word in your postings, yes. In immature cataract, we say it is grayish white in color. And on examination via torchlight, third year posting again, okay, iris shadow is seen. Iris shadow is seen. What do we mean by this? Everybody, let's try to understand. Even though cataract has occurred, even though hydration is occurring, but till now the hydration is limited in amount of the fluid that has entered, so there is no swelling of the lens. So we say if this is my lens, this is my iris, and I throw light obliquely from the temporal side, due to the gap between the iris and the anterior surface of lens, or basically the posterior chamber, this light will form a shadow over the opposite side. Okay, so throwing light from one side, everybody, striking on the iris, and that part of the iris throwing a shadow on the anterior surface of the lens. Okay, now as the cataract progresses, we say what occurs, everybody? Hydration, fluid is coming in and in. So swelling of lens occurs. When swelling of lens occurs, this cataract gets a name, intumescent or intumescent cataract. If again we know our biology, or if we know English, intumescence means swelling due to fluid, everybody, accumulation. Yes, so now intumescent cataract has occurred. Now, due to this swelling, we say which stage is occurring? Mature cataract. In mature cataract, everybody, the color becomes what, everybody? Chalky white. Viva questions. And on examination, again via a torchlight, we say no iris shadow. If you have understood the previous immature, I hope you understand this, because swelling has already occurred. So because swelling has already occurred, I can say if this is my iris, my swollen lens is almost touching the lens. Okay. So there is no space between the iris and the anterior surface of the lens. So when I throw light, everybody, there is no space for a shadow to form. So that is why there is no shadow on the anterior surface of the lens. You have still not treated the cataract. So the cataract is progressing because the hydration is progressing. So as the hydration keeps on progressing, we say we enter the hypermature stage, hypermature cataract. Okay. This hypermature cataract can present in two ways. The first name is a very commonly asked question, everybody. Morganian cataract. In Vivas as a short notes as well as in your MCQs. And the second is known as sclerotic cataract. Now, sclerotic cataract, we say, becomes pearly white in color. And there is associated calcification. Sclerosis is occurring, calcification is occurring, causing pearly white color, pearls. Okay. But what is the more important part? The Morganian cataract. So what is Morganian cataract? Morganian cataract is basically liquefaction of cortex which leads to sinking of nucleus. What do you understand? Liquefaction of cortex. See, remember the one word hydration. That is what we are focusing on. Now we are saying so much of fluid has entered the cortex that all the cortical fibers, the cortical lens fibers have been actually destroyed. And what is left is only water, liquefaction of cortex. Now, when the cortex will become liquefied, again, let me draw the simple lens. This is my lens, in the center is my nucleus, and in the periphery is my cortex. Yes. Now we are saying the cortex has been liquefied. So let's say all this is now fluid, or for the sake of simplification, water. Why was the nucleus present in the center? Because the cortex was supporting it in the periphery. Now, when there is no support in the periphery, what will occur? The nucleus will fall down, everybody. Yes. So the nucleus is sinking in the fluid, I can say. So this is the kind of appearance you will get, that everywhere there is fluid and the nucleus has sunk down, everybody. And that is what is Morgagnian cataract. Okay. I hope you have been able to understand the stages. Let's start from the top again, everybody. First of all, hydration, earliest change, vacuoles, then they coalesce to form layers, lamellar separation. Then what forms, everybody? Cuneiform cataract. So cuneiform cataract, I remember it occurs first because it is long and thin. Remember about your ages, everybody. When you are teenagers, 15, 16, 18, everybody, you are becoming taller and you have thinned out, everybody. Yes. Then as you move into my age, the 35s, the 40s, everybody, you become swollen. I hope you have seen me. Yes, I have become swollen. Yes. So swollen is the second stage, everybody. That is your young adult stage. And then the hypermature stage, when you become old, everything is shrinking out, everything is getting liquefied, you get loose muscles, everybody. So understand that Morgagnian cataract is your hypermature stage. So long and thin first, then swollen, and then everything is getting degenerated. That's how I remember the sequence or the stages of the cortical cataract. Okay. Let me show you some images of cortical cataract. Let's see the first image, image 1 and image 2. Can you identify which cataract is this? It is Morgagnian, is this cuneiform, is this intumescent cataract? Very easily. Okay, let's move on to image 2 first. Image 2 is easier to identify. We are able to see small wedges, everybody, all in the periphery. If you can see, the center is almost clear. Yes? Am I making myself clear? Let me just erase these markings so that you can see this again. Okay, done. So that means this is what cataract? Cuneiform. Now the same thing, if you see against the reddish yellowish fundal reflex, you will be able to see some water droplets kind of thing forming, beginning the formation of small, very small, everybody, wedges. Yes, I hope you can make out all 360 degrees. So image 1 is also cuneiform. I have put both the images against you to be able to make you understand that the image can be on retroillumination, that means against the fundal red reflex, or it can be a straight image, dark image in which you are just seeing the white opacities. Okay, everybody? Now, let's see the third image, everybody. Now, as soon as I see the third image, I am at least clear that this is not cuneiform. So, what is it, everybody? Is it the intumescent cataract or is it the Morgagnian cataract? So, the clue is this. You see this yellowish part, everybody? This yellowish part should have been my nucleus. It should have been in the center. But we see that the nucleus has sunk down, everybody. And that is giving us the clue that we are most probably looking at an image of Morgagnian cataract. I hope we are clear about the images here, everybody. Yes? So these are all the stages of your cortical cataract. Now, what are the complaints of the patient? Patient complains of: Number 1, the patient can complain of diplopia due to the center being clear, so the light going clearly, and in the periphery there is some kind of scattering of light. And secondly, the patient may experience mild glare, everybody. They are not pronounced as symptoms, but yes, certainly they are there. Okay, and that's all about our second type of senile cataract, that is cortical cataract. We move on to the third type of senile cataract now. The third type of senile cataract is the name we had heard a lot in metabolic cataract as well as in the traumatic cataract part, everybody. Posterior subcapsular cataract. Short form we write PSC. It is also known as cupuliform cataract. In practice, actually, nobody calls it cupuliform cataract, but in theory, yes, there is a lot of cupuliform cataract which is written in place of posterior subcapsular. Now, please remember one very important point about posterior subcapsular cataract. Posterior subcapsular cataract causes maximum visual loss. out of all the types or positions of cataract, the maximum visual loss in proportion to the opacity is caused by posterior subcapsular cataract. Why? As in PSC, opacity is present at the nodal point of eye. Again, if you remember your class 11th and 12th optics, nodal point was that point on the posterior surface of lens through which all light rays coming in have to cross. Yes, they come in, they converge, then cross and then diverge. Yes, so that is the point at which posterior subcapsular cataract is occurring, almost the center of the posterior surface of the lens, and that is the nodal point of eye. And that is why the patient experiences maximum visual loss, basically out of proportion to the amount of opacity. Also remember that the patient complains of more visual loss at near than far. Almost always the patient will complain of this. So as soon as you hear the first word glare, how does the patient describe it actually? Let's understand. The patient will come to me and say, sir, I don't have actually a lot of blurring of vision, but I am not able to drive the car at night. When I try to drive the car at night, the light coming from the opposite side is so debilitating that I've almost stopped driving the car. Yes, that is because of glare. Yes, the light is making it impossible for the patient to see at the night time. So we are saying the patient complains of inability to drive at night. See, why am I explaining you, or why am I telling you what is the patient's complaint? Because these are the kind of languages that the examiner is going to use. Again, see, this is becoming a clinical question. Because as soon as the patient is complaining to me of this, the first differential diagnosis that I am forming in my head based on the age and all the other features is posterior subcapsular cataract. And that is what basically essentially becomes an MCQ. MCQs are nothing that are out of the world. They are just what we are discussing with patients each day, everybody. Yes? Now, also remember that because of its central location, as I just said, posterior subcapsular cataract is present at the nodal point, which is the center of the posterior surface. So, as soon as I say the word central, what clicks in your mind? The same concept that should have clicked in nuclear cataract, that the patient will have more loss of vision in daytime or nighttime? Yes, daytime, guys. More loss of vision in daytime. Yes, I hope we are clear about this. I hope we understand this. There is no confusion in this, right? Now, what about the pathology? How does this occur? Okay, so this occurs due to dysplasia of E cells. I hope you remember through the anatomy part again that the epithelial cells are anterior A cells and equatorial E cells. Yes, so dysplasia of E cells occurs, which leads to their posterior migration. And during this posterior migration, they are getting enlarged. Okay. So now this posterior migration and enlargement leads to formation of something called as bladder cells or Weld cells. So when they accumulate, they form a plaque-like opacity, and that is what is known as posterior subcapsular cataract. I hope we are clear about this, everybody. The two words are important. They can be used in your MCQs. The bladder cells or Weld cells have never been previously asked, so maybe a new question for all of us, right? Now, let us see the image, everybody. So this is what a posterior subcapsular cataract looks like. I know you are confused. You are not able to comprehend. But again, go on to the word oblique illumination. Now, this time the image is showing you light from this side, everybody. Yes, zoomed photograph. So first of all, it is falling onto the cornea. Then it is falling onto the anterior chamber. And then all this is your lens. So if you see, this is the anterior surface of lens. we are going in, and this is the posterior surface of lens. On the posterior surface of lens, you see an opacity. Nowhere from the anterior to the nucleus, you don't see an opacity anywhere. You see an opacity just at the posterior surface of lens, and that is what helps us to diagnose it as a posterior subcapsular cataract. I hope we are clear about this, everybody. Yes? Now, moving back, everybody, to our theory. So, a favorite question of examiners is, what are the causes of posterior subcapsular cataract? So when we are talking about the causes of posterior subcapsular cataract, obviously we are talking about senile age. Yes, senility. That's what we are discussing. We have already discussed a lot of causes. I'm just going to list them for you. If you remember, take it as your revision, everybody. Galactosemia, oil droplet cataract, posterior subcapsular. Number 3, myotonic dystrophy, Christmas tree cataract. It was again posterior subcapsular. Then everybody, rosette shaped cataract due to blunt trauma was also posterior subcapsular. And complicated cataract, breadcrumb appearance with polychromatic luster, that was also posterior subcapsular. So all this we have actually already written. I have just compiled this list for you. Apart from this, is there any other cause? Yes. A very important cause is steroids. Okay. Now, all of us have heard, even the general population knows that steroids have side effects if taken inappropriately without any advice. Yes. So, what are the ocular side effects of steroids? There are 2 ocular side effects, which we remember through a mnemonic GTCS. Okay. The seizures, GTCS, everybody, I hope you understand the mnemonic. So, what is the mnemonic? G for glaucoma. Glaucoma is more common with topical steroids, whereas C for cataract, which cataract we are discussing, posterior subcapsular, is more common with systemic steroids. Okay, so these are the 2 manifestations of steroid-induced glaucoma or steroid-induced cataract, and along with the type of drug administration that they are more likely to occur with. Now, moving on, everybody. The next important cause is exposure to X-rays. So this can be an occupational hazard in technicians, the technicians who are there in radiology department, everybody, if they are not using appropriate protective equipment. Also, another important cause, everybody, is neurofibromatosis 2. It can also occur as a side effect of busulfan drug. Okay, everybody. So these are some of the important causes of a case of posterior subcapsular cataract. And that's our very important 3rd type because it causes maximum visual loss. Moving on to the last type of senile cataract, everybody. The last type of senile cataract is anterior subcapsular cataract. Just like posterior subcapsular, everybody, if the opacity is just below the anterior capsule, we are calling it anterior subcapsular. There is no question which is asked on this apart from the question, what are the causes? Okay. So the causes are, I can say, number 1, atopic dermatitis, skin disease. The name of the cataract is called as shield cataract. Then the drug amiodarone, chlorpromazine, gold deposits. Okay, these are the 4 important causes. Now the mnemonic which is forming, everybody, is A for atopic dermatitis, A for amiodarone, C for chlorpromazine, G for gold deposits. AACG. And that's the 5th cause, AACG. What is the 5th cause? Acute angle closure glaucoma. So as far as mnemonics go, guys, I love this mnemonic because there are only 4 letters and those 4 letters are making us remember 5 causes. So AACG itself, and then A for, C for, and G for, everybody. So these are the 5 important causes of anterior subcapsular cataract. And if you realize we are done with our first group of cataract, that is acquired cataract. Everybody, let's revise quickly. Metabolic cataract, we had read 4 diseases: diabetes mellitus, mainly snowflake cataract; oil droplet galactosemia; myotonic dystrophy Christmas tree; Wilson's disease causes sunflower, and also causes a very important thing, Kaiser Fleischer ring, which we have discussed in detail, seen all the photographs. Traumatic cataract, blunt trauma causes rosette shape, again a beautiful flower kind of a photograph. I hope you will be able to remember. Infrared rays, you should think about glass blowing, glass blowers, then lightning, anterior capsular. Complicated cataract, please remember UMAR, uveitis, the most common cause, the mnemonic, the other causes. Breadcrumb appearance with polychromatic luster, and finally senile or age related. 4 types based on the site: in the center nucleus, in the periphery cortical, posterior subcapsular, the most visually handicapping because it is present at the nodal point, and lastly anterior subcapsular cataract.